translator is pretty accurate.
Yeah. Mm. So it's like a movie. Yeah. When we see your Hollywood movie,
Yes,
yeah, we
it's
can see
the
the
subtitles.
subtitle. Yes. Eka kenapa belum ngumpul ya tuh Deas ya yang perbaikan?
Hari ini Prof katanya mau dibaca bareng Prof. Mungkin
Oh,
insya Allah
after
hari
this
ini.
one. After this.
Ya, sama Dias maksudnya Prof.
Oke. Oh ya ya ya. Nggak, kalau bisa sama Rob aja.
Prof, iya, Prof. Iya, Prof. Coba
Nggak
Dias
apa-apa.
hubungin Dokter Eka. Iya,
Ya
ya.
ya. Ya, Rob, Professor Rob, regarding to our last improvement for the publication,
Yes,
and Eka and Deas, maybe after your lecture, do you have maybe some times to
sure.
final discussion? Okay, after
Yeah,
this lecture. Okay, yes, yes.
Ya, thank you,
So
Prof.
yeah, Eka will present it for you before we present it to the APS journal.
very good.
I'm wearing the Indonesian coach, so is it safe? No, it's okay.
Yes,
Use my flag.
you've got to represent the country well.
Yes. Okay, Rob, I do believe that my boarding time is already come now, and yeah, the officer already called us. Okay.
Okay, have a safe flight.
So thank you so much for your effort, ya, Deas and Eka. Saya boarding dulu ya,
Ya,
siap-siap
thank you.
ya.
Terima kasih, Prof. Iya, Prof.
Adik-adik mahasiswa silakan lanjut ya. Thank you, Prof. See you then. Bye
Very
bye.
good. Safe travels.
Yeah. Good evening. I will I will I will experience the same day on
Yes.
America, yes. Because it is already morning and I will arrive at morning. Okay. See you then. Bye bye. Thank you, Rob.
Bye.
Bye bye.
Prof, please wait maybe 10 more minutes, Prof.
Sure.
Our students still process join to our Zoom.
Yes. I wanted to make sure that the point worked, and so we've tested it out, and technology seems to be working for us.
Yeah, Prof.
Progress. Udah ada profesornya.
Anjay, kita sekarang sama Ro. Dek, mungkin bisa diinfo ke teman-teman yang lainnya. 5 menit lagi kita akan mulai ya, Dek. Yang lain bisa langsung join. Yang sudah join bisa open cam. Seperti biasa, nanti pukul 8 saya coba screenshot ya. Untuk absensi ketepatan waktu kalian ya. Oke deh, ini pukul 8 ya. Saya nanti coba buka, habis itu saya coba screenshot untuk absensinya ya. Oke, Prof, maybe we can start our session, Prof. Oke, Assalamualaikum warahmatullahi wabarakatuh. Good morning, Prof. Okay,
Morning.
we are very happy because today we can attend this insightful session with world-class professor. I am Deas, Prof, who will be the moderator in this morning. For this session of insightful with world-class professor has joined with us Professor Robert G. Carroll. He is a professor of Brody Medical School, East Carolina University. We are happy to have you back as a guest lecturer here. He has also been a guest lecturer in Insightful session several times in last 3 years, maybe, yeah, Prof. Several months ago, Prof came to Palembang and gave a lecture at Sriwijaya University also, yeah, Prof. And he is also chair of the education committee to the International Union of Physiological Science. And this morning, Prof will give a lecture to all of us. Maybe without further ado, you can start your session, Prof. The time is yours.
Terima kasih, Dr. Diaz.
Ya, terima kasih, Prof.
Let's see. And Assalamualaikum, selamat pagi, and thank you for joining me this morning. It's been a very exciting week for us in Greenville, and the big excitement was you see a picture of my new grandson. He was born 1 week ago. So I actually have a grandson who was born on Leap Day. So his birthday will only come once every 4 years since he was born on February 29th.
Yeah, congratulations, Prof.
Thank you. Exciting times. So I'm also experimenting with a translation program that's at the bottom of the PowerPoint slides. So hopefully you can use this to follow my English if some of my phrasing is not familiar to you. My talk today is going to focus on body fluid compartments and physiological solutions. And at the bottom, you have my email, should you choose to contact me and further discuss this topic. As with every lecture, it's important to begin with a series of learning objectives, and we will return to these objectives at the end of the lecture and see how well the lecture has done in achieving the objectives. When looking at the body, it's important to keep track of all the different organ systems and how they contribute to body function. So I like this slide a lot because it shows that the entire body is wrapped within the skin, an integumentary system. And there are a couple of breaks in that integumentary system. One is through sweat glands. Another is through the mouth, where the whole GI system is lined with epithelial cells, which physically separate it from the body. The pulmonary system has direct access to the outside world, and the renal system has access to the outside world. With those exceptions, the body is an amazingly constant internal environment. Plasma electrolytes and interstitial fluid electrolytes are remarkably similar. The circulatory system plays a role in making that similar. What we're going to talk about today is when there's disorders in the fluid balance within the body and what that means in terms of clinical practice. So when you look at the body is mostly water. The total body water ranges from about 50% to 70% of the body weight. So for an average person, which is usually identified as a 70-kilogram male, that works out to be about 42 liters of body fluid. That fluid is not uniformly distributed. This slide shows in blue the locations of fluid within the body, and then the barriers separating them. Most of the fluid within the body, 2/3 of the fluid, is within the cells, the intracellular fluid. The other third is outside of the cells, the extracellular fluid. Of that extracellular fluid, 3 liters is in the plasma, and 11 liters is in the interstitial fluid, the space in between cells. The lymphatic system represents a pathway to go from the interstitial fluid back into the plasma. The barrier separating the plasma from the interstitial fluid is the capillary endothelial cells. The barrier separating the extracellular fluid from the cell water is the cell membrane. So the talk today, we're going to focus on what is going to drive fluid shifts across those barriers. Clinically, it's very useful to think in terms of the place that you will have access to is the plasma through intravenous fluids. If you ingest food, first it gets absorbed into the plasma. So all of your intake and ingestion and metabolism generate a change in the plasma space. Similarly, for the output, the kidneys, the lung, feces, and sweat can all be thought of as eliminating fluid from that plasma space. We have to establish a couple common definitions: osmolarity and tonicity. So, 2 related terms. Osmolality is milliosmoles of solute per kilogram of water, and osmolarity is millimoles of solute per liter of water. For dilute solutions, those terms can be used interchangeably, and for physiology, we only deal with dilute solutions. The reason you care about the osmolarity is because there's a property of water called the activity of water, which decreases as the osmolarity increases. The colligative properties of solution depends on the number of molecules and not their nature. So 1 albumin with a gram molecular weight of about 20,000 has the same impact as 1 sodium ion with a gram molecular weight of about 35. Osmolarity is one of those colligative properties of solutions. For example, I have 2 compartments. I have compartment A on the left and compartment B on the right. Separating them, I have a barrier which prevents these particles from being able to diffuse between the 2 spaces. My question for you is, which way is water going to go? Is water going to go into side A, or is water going to go into side B? And let me see how I can do this. If all of those who think water is going to go into side A will raise your fingers, give me a thumbs up sign. That will let me know whether you agree or not. If you think the water is going to go into side B, give me a thumbs up sign. So which way is it going to go? Into A? Okay, I'm getting some thumbs up. Into B, side B? Not getting any, good, okay. So the correct answer is the water is going to go into side A. I don't care if you think about it as the water going toward the particles or the water going down a water concentration gradient. As long as you have the water going into side A, we're in good shape. Okay, so I can keep the chat open over on the side. That gives us another way to communicate. So on the definitions, osmolarity is something that's measured in a laboratory setting. Tonicity describes the ability to alter the volume across the cell membrane after the particles have diffused. For our purposes, glucose and urea are going to be osmotic, but not tonic particles. And then oncotic pressure describes the ability to alter volumes across the capillary after the particles have diffused. So if I take a red blood cell and place it into a solution, 300 milliosmol solution, when I do that, the cell swells, the cells gets larger. Compared to the red blood cell, what was the characteristic of the solution that it got put into? And you can answer A, B, or C in the chat feature. Okay. There's pretty good agreement that C is the right answer. And when we polled our students in our class, about 2/3 of them thought that C was the correct answer. About 1/3 thought that B was the answer. So let's talk about the mechanics. What happened here? If I take a red blood cell and the osmolarity of that cell is somewhere around 280 milliosmoles, if I place that cell into a hypotonic solution, the water is going to come into the cell and cause the cell to swell. If I place it into a solution where the osmolarity is less than 200 milliosmoles, it will swell so much that the cell will rupture or break. So you'll get hemolysis if you put it into a red blood cell into water. If I place the cell into an isotonic solution, there'll be no change in its volume. If I place the cell into a hypertonic solution, water is going to come out of the cell. The cell will shrink, and that process is called crenation. So I need to stop for a moment and go back and review a basic principle, indicator dilution. For indicator dilution, if I have an unknown volume of fluid in this container and I add an amount of dye, I end up with some colored water. But it's possible to take a sample from that colored water and then calculate the concentration. As long as I know the final concentration and I know the amount that I added, you can back calculate what the starting volume was. Now, this doesn't matter if there's already some dye present in the beaker. I have a little bit of blue in it. I add even more dye. The color gets more intense. The equation just changes to the amount you added divided by the change in concentration caused by adding the dye. It also doesn't matter if things are moving, if things are flowing. So for the lungs, it's possible to look and see how much oxygen is being taken up per minute. And if I know the difference in the oxygen content from the pulmonary artery and the pulmonary vein, I can calculate what the cardiac output is for the individual. So the indicator dilution process lets you identify volumes within the body. When I look at my three body fluid compartments, I've got my plasma, I've got the interstitial fluid, and I've got the cell water. If I want to know what my plasma volume is, I need to have a compound that only stays in the plasma. So albumin and Evans blue, which binds to albumin, have that characteristic. If I want to know what my extracellular fluid volume is, it's possible to use a compound called inulin or else a radiolabeled sodium in order to measure the volume. If I want to know what the total body water is, I can't measure that directly. I'm sorry, total body water, I can measure it using deuterium or antipyrine. If I want to know what the cell water space is, I cannot measure that directly. I have to measure the total body water and then subtract from that the extracellular space. So you can use indicators to identify unknown volumes in the body. For this figure, I've got the same three compartments. I've got my capillary, which is your plasma. I've got the interstitial fluid beside it, and then I have my cell water over on this side. Water is able to freely distribute through all three spaces. It's small enough that it easily gets across the endothelial cells of the capillary, and the aquaporins in the cell membranes allow water to get across the cell membrane. Proteins have a hard time getting across the capillary endothelium. Sodium and potassium, because they're ions, freely cross the capillary endothelium, but have a hard time getting in and out of the cells. So when you look at what is going to make water move, it's compounds that can't get across the barrier are going to drive water movement. When you look at fluid exchange from the capillary to the interstitial space, you're going to focus on proteins generating the oncotic pressure within the capillaries. When you look at the compounds which are going to cause water movement in and out of cells, you're going to focus on the electrolytes, the sodium, the chloride, as the particles that will alter cell water movement. So proteins are going to be the ones that give you an oncotic pressure. The electrolytes are going to be the ones which give you a tonic pressure. So for fluid therapy, if you look at a hospital patient who's not running a fever, not eating much, and inactive, they require less than 1 liter of free water each day in order to maintain balance. If those patients have a fever, if they're sweating, they have burns, tachypnea, polyuria, GI loss, you're going to have to increase the volume of fluid. You're actually going to decrease that volume if the patients are in kidney failure where they're not producing much volume, or if they're edematous or hypothyroid. What your challenge is going to be as physicians is to correct the imbalance that's created in the patient. So for your infusion solutions, you have a whole bunch of choices. You go into a storeroom, all of these guys will be available to you. You can infuse blood, you can infuse plasma. You can infuse packed red blood cells. You can infuse salt solutions. Isotonic crystalloid solutions include the 0.9% saline, lactated ringers, and plasma-lite. You can choose non-isotonic crystalloid solutions, the 0.45% saline, a half normal saline, or a hypertonic saline. You may choose to infuse glucose, which is a D5W, 5 grams of dextrose per 100 mils, or you can infuse colloids, such as albumin, hydroxyethyl starch, and gelatin. You'll use these guys as plasma volume expanders. Now, for me, the nomenclature, it helps to understand where the nomenclature comes from. This 0.9% saline is actually a formulary. It's telling you how to make the compound. It's 0.9 grams of sodium and chloride per 100 mils of water. The percent means per 100. Similarly, the D5W is a 5% solution of dextrose, 5 grams percent of dextrose, 5 grams of dextrose in 100 mils of water. So this table is pulled from the New England Journal of Medicine about 10 years ago. And it gives you the electrolyte composition of plasma, normal saline, lactated ringers, and a compound which was new at that time called plasmolite. So take a look at those numbers and decide which of those you think would be the best solution to be used in a hospital setting. And you can type your answer into the chat box. Okay, so we have a couple votes for normal saline, one vote that says all three will work and all three will indeed work. The individuals who said normal saline, that is the one that is most commonly used in hospital settings. The one that's most biologically appropriate is the plasmolite. The reason why normal saline is used instead of plasmolite is, at least in the US, a liter of normal saline for the hospital, they're going to charge about $8 to $10. For plasmolite, they're going to charge about $400. So plasmolite is the more biological solution. It just costs too much. And the biological action that you want, you can get from normal saline. So normal saline is the one that's used most commonly. However, I tell my students, if I'm ever in front of them and I'm a patient, that I'm good for the rest of the money. They should give me the good stuff. They should give me the stuff that aligns most appropriately to my physiology. So now I have another question. Following an estimated hemorrhage of about 1.5 liters, how much of the normal saline should be infused intravenously to restore circulating blood volume? Okay, let's wait until we get a few more answers. Okay, so C seems to be emerging as the most popular answer. And when we asked our students, the vast majority went for C. The correct answer is E. So we're going to have to talk about why that is. When you look at the infusion of a solution, you've got to keep track of where that solution is going to go. So you've got a plasma space, you've got an interstitial space, and you've got a cell space. When you infuse normal saline, all of the expansion happens in the extracellular space, but that's both the plasma and the interstitial space. So about 1/3 of what you infuse stays behind in the plasma. The other 2/3 goes into the interstitial space. So when you're in your surgery clerkship and you take the advanced trauma life support course, the guidelines for resuscitation is you need to put in 3 volumes of isotonic saline for every 1 volume of blood that a patient has lost. If you were putting in just blood, then the 1.5 liters would be the right answer. But because you're not putting in blood, the solution you're infusing does not stay within the plasma space, but it distributes into other spaces. So you have to keep track of where the solution you put into the body is distributing. In contrast, if I would give 3 liters of water or 3 liters of D5W, because the water has a lower osmolarity than plasma, it's going to cause a drop in my osmolarity, both in the extracellular space and in the cell space. The 3 liters of water, about 1 liter is going to stay in the extracellular space. About 2 liters are going to go into the cell because the body fluid distribution, 1/3 of the total body water is extracellular, 2/3 is intracellular. So what I'd like to do is test the concept. For physiology purposes, glucose and urea are able to get across cell membranes. You've got transport proteins which are going to let them cross the cell membrane. Sodium and chloride do not, and if any sodium does go into the cell, it's kicked out of the cell by the sodium-potassium ATPase. So I've got 5 different curves set up here. For curve A, I've got an increase in cell volume that persists over time. For curve B, I had no initial change in volume. Excuse me. No initial change in volume, but then the volume increased. For curve C, I should have the C out here. There's been no change in the cell volume. For curve D, there's an initial decrease in cell volume, but then it comes back to the starting point. And for curve E, there's a decrease in the volume, and then that decrease persists. So your challenge is to identify which one of these solutions listed here, blood, a 3% sodium chloride, 0.9% saline, 0.45% saline, E5W, or if I would add some extra urea to lactated ringers, which one of those solutions is going to be isotonic? Which one is going to be hyperosmotic? And then you should be able to match the solutions to one of these curves. Do you have a sense of what the challenge is? So I'd like you to take about 3 to 5 minutes. And if you're in a setting where you can talk to each other, talk with each other, but take some time and puzzle your way through this problem. You're right, from the curve, line C is isotonic, but which of the list of possible solutions that you have up here would be isotonic and would behave like line C? Okay, let's go through these and talk about the different solutions and their behaviors. So in terms of which ones were isotonic, which ones did not result in a change in volume distribution across the cell, the 0.9% saline, the lactated ringers, and the blood and plasma would be isotonic solutions. In contrast, the higher concentration of sodium chloride, the hypertonic, or the higher concentration of sodium and chloride is hypertonic. So if you would use this solution, it would actually cause the cells to shrink. It would pull water out of the cells. The 0.45% sodium and chloride is sometimes referred to as half normal saline. It's got about half as much sodium and chloride as does normal saline. And that, because it's got a lower osmolarity than plasma, that would cause the cells to swell. And then the D5W. Initially, the D5W starts off as an isotonic, as an isosmotic solution, but then over time, the glucose goes into the cell and it becomes a very dilute solution, causing the cells to swell. So the treatment with the D5W or the half normal saline would cause cells to swell. The treatment with the hypertonic saline would actually cause the cells to shrink. There's a difference between the acute and the chronic responses. If I have a sustained, as in days, weeks, kind of an osmotic imbalance, that will actually cause the particles to redistribute within the cells. So if the extracellular fluid is very dilute, that's going to cause water to come into the cells. One way the cells can limit the amount that they shrink is by increasing the activity of the sodium-potassium ATPase. Because every time that pump cycles, it eliminates free sodiums and lets in 2 potassiums. So there's one net particle loss every time that pump cycles. If the extracellular fluid becomes too concentrated, then I can slow down the activity of that sodium-potassium ATPase. The brain in particular has the ability to generate particles by metabolism if there's a prolonged change in the extracellular fluid osmolarity. Because of this, you have to be very careful when you're trying to correct chronic osmolar imbalances. So the physiologist in me, if a patient has an increase in their osmolarity, the physiologist in me says, well, give them something dilute because you're trying to bring them back into the normal osmolarity. The clinical reality is you will give them isotonic saline because mostly you're concerned with keeping them alive. You'll worry about the long-term regulation and bringing them back into osmotic balance later on using diet, water intake, or water restriction to try and fix things. So isotonic saline is the preferred infused solution, even when there is an osmotic imbalance. So what happens on that, if we would add it to the figure, is if the cells are exposed to a dilute solution and they increase their volume, the cells are going to increase the activity of the sodium-potassium ATPase and get rid of particles, and then that helps relieve some of the swelling that's taking place on the cells. There's a clinical reference called Up to Date, which our library has access to. And it's very useful. It provides a very understandable description of how things work. And when I try to get a better understanding for clinical applications of material, I turn to this as my preferred site. So in looking at the D5W, the 5% glucose solution in water, the reasons why you would select that is if you're trying to provide calories and/or fluid replacement. And they're saying the inappropriate use of these types of solutions, especially in pediatric patients, can lead to significant morbidity and mortality due to hyponatremia. You can dilute out their plasma sodium too much. For hypernatremia, for patients who show up with an elevated plasma sodium, you have to use caution when you're doing this because of the elevated intracranial pressure. So it's not it's an off-label use for the compound. It's not something that's recommended that it's used, and you have to be very, very careful. And each hospital will have their own protocol for how to use this to try and correct hypernatremia in patients. So staying with the big picture, I've got the cell water, the extracellular fluid split between the plasma and the rest of the extracellular fluid. If I look at my diet and the metabolic production of water, that water addition starts first in the plasma and then can redistribute to other places. When I look at my urine, urine starts out as an ultrafiltrate of plasma. Feces and insensible water loss can be thought of as coming from the extracellular fluid. So usually we take in about 2.5 liters per day. We excrete about 2.5 liters per day. The body remains in good balance. The two parts of this that are regulated is thirst is going to regulate your dietary intake, and ADH is going to regulate your urinary loss of water from the body. So as you look at the body fluids that are commonly lost, most of them are isotonic. The form of diarrhea that is normally found in adults produces an isotonic fluid. Blood in a hemorrhage is an isotonic fluid, and vomiting is actually an isotonic fluid, the GI contents. There are a couple of hypotonic solutions that can be lost. Sweat, saliva, and the type of diarrhea that generally impacts infants. The sweat being a hypotonic solution gives some of our students, that concept gives some of our students trouble because you think about sweat as being very salty. But what happens when sweat is produced by the body, its osmolarity is at about 200 milliosmoles. When it's on the surface of the skin, the water evaporates, leaving behind the salt. So by the time you taste it, then your perception is that it's a very salty sweat, but the reality is when the body produced it, it is a dilute solution. Another thing to keep in mind when you look at the loss of GI fluids is what is the normal turnover of fluids. So for an infant, weighs about 3 kilograms. Their total body water is somewhere around 2.3 liters, but they turn over 1/6 of that, some 16% every day. Adults, we only turn over about 6% per day. Diarrhea, volume problems in infants get to be life-threatening very quickly because they turn over such a large fraction of their water. Where when an adult gets diarrhea, you say, well, give it a couple days, try and stay hydrated, you're going to be okay. But for infants, they can get into life-threatening situations very quickly should they get diarrhea. So one of the take-home messages from this talk is that you've got to separately track your body volume and your osmolarity. So I've got a 3x3 grid here. Normal is in the middle there. I can either have an increased body volume, a normal body volume, or a decreased body volume. For osmolarity, it can be low, normal, or high. So if I move away from my normal distribution, one way that could happen is if you would ingest water. If you ingest water, your body volume goes up, but your osmolarity is going to go down. If you sweat and then drink some same volume of water, you can bring your water back into balance, but because you lost sodium and chloride in the sweat, you would have a decreased osmolarity. If you lose proportionally more sodium and chloride than water, say from using a diuretic, then you would have a decreased body fluid volume, but you would also have a decreased osmolarity. If the osmolarity doesn't change, but your body volume does, one way to do that to increase your body fluid volume is to infuse isotonic saline. One way to decrease the volume is to have a hemorrhage or diarrhea, or just to have a loss of some isotonic fluid. If I want to look at examples where the extracellular fluid osmolarity is increased, if my body volume is also increased, one way to cause that would be to infuse the hypertonic saline. One way to keep a normal volume but an increased osmolarity would just to be ingest salt. And then one way to have a decreased volume but an increased osmolarity would be to have prolonged dehydration from sweat or the types of diarrhea that would impact an infant. So the 6 letters on here, A through F, actually align with the figures that are on this slide. So I've got the same information. I've got the volume on the x-axis where my cell water is 28, my extracellular fluid is 14, and then my osmolarity on the y-axis. So if I have a volume contraction and the patient is isotonic, that is, there's no change in their osmolarity, you should be able to conclude that the entire loss came from the extracellular fluid space. As long as the osmolarity doesn't change, you do not alter the cell water distribution. In contrast, if the patient, when they show up, if the patient is hypertonic, they have an elevated osmolarity, then you'll know that you have both a loss of fluid from the extracellular space, but also from the cell space. So what happens is, as you lose fluid from the extracellular space, the osmolarity in the extracellular space increases, and then that will pull water from the cell volume into the extracellular space. If you want to try and fix this patient, the volume that you have to give them, you have to account for both the loss from the extracellular space and the cell water. For this patient, if you want to try and fix the volume defect, you only have to worry about the extracellular fluid shift. If a patient shows up and they've got a low plasma osmolarity, then you know that the volume deficit came from the extracellular fluid space, and there was an augmentation of that. There's an even larger loss of extracellular fluid, which has gone into the cell. So when you try and fix this, you have to be careful because you're dealing with an already expanded cell water space. The bottom three figures show what happens when there's a volume expansion. So if you would infuse an isotonic solution, it would just stay within the extracellular space. It would not alter the cell volume. If you would infuse a hypertonic solution, you get an extracellular volume expansion, but pull additional volume from the cell water. So you get an even larger increase in the extracellular fluid. Or if the patient is hypotonic, you know that you've expanded both the extracellular space and the cell water space. So where this has gotten used in clinical settings is the military became very interested in using an isotonic saline for combat resuscitation. The reason for that is the medics would only have to carry a relatively small volume of fluid, and when you could administer it to a soldier who's had a hemorrhage, then it would pull additional fluid from the cell water. So the plasma volume would get expanded both from the volume you added and also from the additional cell water that got added. The trouble with this is that the survival rate was lower for patients receiving the hypertonic solution. And that's because in emergent situations, the site of hemorrhage is often not controlled. So it got their blood pressure back up, but then they started bleeding again. And so they had an increased volume loss from the secondary hemorrhage. The one group of patients who did show improved survival were patients with a head injury. In a head injury, the big problem is the swelling of the brain in the cranial vault. So by giving the hypertonic solution, it actually pulled volume out of the neurons and reduced the volume that was in the cranial vault. So the next step of this is I'm a big believer in formative assessment, that is practice questions that are going to let you test your understanding of the material. So I got a series of practice questions for us to go through. Take a look at this question and type your answer into the chat box. Okay, so there's pretty good agreement at C. I'd actually forgotten this was my first question before I told you the story about the military use of a hypertonic saline. So we'll go on to the next question. Okay, we've got pretty good agreement that E is the correct answer, and that is indeed the correct answer. So moving on to the next question. Okay, this one seems to be causing some concern. The correct answer is A. So let's go over and talk about why. So I've got a series of graphs. The top three graphs are where there's a loss of volume, a volume contraction. The bottom three graphs are where there's a volume expansion. On the x-axis, I have volume with 0 in the middle here. So the extracellular fluid is 14 liters of volume that way, 28 liters inside of the cell. If I've had a hemorrhage and it's a big enough hemorrhage that it's going to cause a drop in my blood pressure, the volume, the fluid that got lost was isotonic. So even though you've lost volume, you've not changed the osmolarity of the body, of the extracellular fluid. If you don't change the osmolarity, all of your volume loss is going to be restricted to the extracellular space. For hemorrhage, 1.5 liters is getting into class 2 out of the 4 classes of hemorrhage. If you lose 3 liters of blood, you're going to die. So it's not that you don't have volume in your body, but because you never changed your osmolarity, you cannot access the cell water. So all of the change, if you take out a hypertonic, if you lost the isosmotic fluid, all the changes are just going to be limited to the extracellular space. One analogy that has helped our students to understand this is if you think about a kettle of soup that's evenly distributed. If you take a ladle and you go in and you take out 1 serving of soup, you've lost the volume, but you've not changed the concentration of what's left behind. So even though you've lost volume, the concentration of sodium, proteins, all that stuff remains the same. Okay, so I've got a hemorrhage of 1.5 liters and the loss is restricted to the extracellular fluid space. Now you want to fix it. What solution would be most appropriate to try and restore homeostasis? What would you like to do about this? Yeah, A would work if you gave 3 times as much, but let's pretend A is not a choice. From B through E, which of those would be the preferred solution to restore homeostasis? Okay, so D is emerging as the preferred choice, and that is indeed the correct response. It's very logical. Whatever the patient lost, give that back to them. So you want to try and fix the problem by giving back whatever it was they lost. If you've got time to type and cross-match, resuscitation with blood is the preferred solution. So now a different patient. Again, we're in good shape. B is emerging as the most common choice, and that is the correct choice. So since you know what's wrong with the patient, what do you want to do about it? What infusion solution would be appropriate? And this is actually a place where the physiologist in me likes C. The clinician, my colleague who's an emergency medicine clinician, assures me that A is the right answer in the emergency department. So to restore homeostasis, you would want to give a dilute solution, but the clinical management of patients who are dehydrated is going to be isotonic saline, because you don't want to run the risk of causing the brain to swell any more than it should. And I'm going to have to define a kidney disease. Nephrotic kidney disease causes damage to the glomerular capillary basement membrane. And because of that, proteins can get lost from the body. Okay, this one's a little unfortunate because you don't have enough about nephrotic and nephritic diseases. The correct answer is actually A. The patient's osmolarity in nephrotic diseases do not change. So because the osmolarity doesn't change, you don't alter the cell volume. This one wouldn't be a fair question for the types of information that you have available to you. So I should not have presented that question. However, when knowing that nephrotic kidney diseases and nephritic kidney diseases both cause the loss of proteins, what solution would be most appropriate to try and restore homeostasis in those individuals? E is emerging as the most popular answer, and that is indeed the correct answer. One of the reasons for that is that the patient has a lot of edema. So by giving colloids, you help pull volume from the interstitial space back into the plasma space. So you help prevent some of the edematous fluid accumulation characteristic of the kidney disease. Okay, we have a pretty good agreement that F is the correct description. And that is correct. So what happens is when you ingest 2 liters of water, you get a dilution of both the cell water space and the extracellular fluid space. Both of those spaces end up being expanded. There's a drug called ecstasy, and one of the characteristics of individuals who use that drug is it causes a severe thirst. So they end up ingesting massive quantities of water. Because they ingest that much water, their plasma osmolarity drops. And one of the dangers for that drug is the swelling of the neurons in the brain can actually lead to seizures. So ingesting that much water quickly can be life-threatening because of the swelling of the brain. So for that person, what would you want to do to try and restore homeostasis? Okay. B has emerged as a clear favorite for the answers, and that's correct. This is one time where the hypertonic saline this is clinically what is recommended for use when trying to prevent cerebral edema caused by excess fluid movement into the brain cells. So when you look at the learning objectives, you should be able to, for our medical students, given the body weight, they should be able to estimate what the fluid volume is within the different compartments. We have not talked about it in the lecture, but I provide them with a list and range of normal plasma values and tell them to memorize those. Use indicator dilution to measure volumes. Talk about how water intake and loss affects the distribution of total body water, and then predict the changes in extracellular and cell water and osmolarity caused by infusion of the different solutions that you have available to you. And with that, we have covered the content for the lecture. I'd be glad to take questions about the material. So you can type the questions in the chat, or if we can figure a way to have you unmute yourself.
Ya, silakan Dek, ajukan pertanyaan ke Prof ya, boleh lewat chat, boleh juga langsung. Silakan di-unmute. Okay, so then you are allowed to ask question to Prof. Is there any questions? Ya Dek, silakan. Masing-masing kelas harus ada perwakilannya Dek ya. Kalau enggak, saya tunjuk aja ya.
Sure. The question in the chat is, why is it that plasma osmolarity drop can lead to cerebral edema? So normally the osmolarity inside the cell and outside the cell is about the same, some 280 to 300 milliosmoles. If you ever get a very dilute extracellular space in the plasma, say it drops down to 270 or 260, then you've got a very dilute extracellular fluid, many more particles inside the cells of the brain, the neurons. So just as in the first case that we looked at, the water is going to move toward the particles. As that water moves into the cells, it causes swelling of the neurons. And the brain is the one particularly susceptible to it because the brain's encased in the cranium, in the cranial vault. There is no room for it to expand. If it was skeletal muscle or something like that, the muscle could expand, but because the brain's locked within the cranium, the skull, you're not able to expand the brain without creating an increase in intracranial pressure. Books or videos that you recommend to get deeper into this topic? I'm actually a big fan of the book, the physiology book by D. Silverthorne. And I know Prof. Irfan is working to get that translated into Indonesian for use by students in your country. The other one, the more detailed textbook on it, would be the Guyton and Hall book. I was fortunate enough that I did my postdoctoral training with Doctors Guyton and Hall, and they have a truly excellent and clear explanation for physiological topics within their books. So those are my two preferred physiology books. Separate from that, I'm not a clinician, I've not had any clinical training, but if I need to understand clinical things, I usually go to a nursing pathophysiology book. So pathophysiology is a great way to see how this manifests in disease states. So next question in the chat. See, advertising for beverages help with body fluids. Consumption fills the body's hydration needs, but affects the distribution between the cell and extracellular spaces. Energy drinks and others have different properties that can affect the process of absorption in the body. So how does the consumption pattern affect the body fluids? And does it have long-term implications for fluid balance and overall health? So the sports drink industry in the United States, and I think globally, is a moneymaker for companies. When you look at the best solutions to rehydrate, it's actually ones that have an osmolarity close to plasma osmolarity. And when we look at our athletes, in the college athletes and professional athletes, milk is the best solution to restore electrolytes after a bout of exercise. So the commercials will all tout Gatorade or Pocari Sweat or some of the electrolyte solutions. But the isosmotic, the solutions that are close to isotonic, isosmotic, get absorbed more quickly. So the ones that Gatorade and those things are usually hyperosmotic. The one that is isosmotic is Pedialyte, and that's available in this country over the counter. And it was initially developed to give infants with diarrhea to try and keep them from becoming too dehydrated. The long-term implications for health, as long as you have access to water, turning over a lot of body fluid does not represent a health risk. It's only if thirst and urinary control are not adequate to keep the balance intake against the balanced outtake. So for energy drinks, caffeine can actually enhance. Some years it's a mild diuretic, not a big diuretic, but a mild diuretic. And so that's not that great for holding on to water. The best hydration fluid for athletes working out is actually milk. And then anything that puts back the electrolytes that you lose is going to help restore balance. The one last amusing story about Gatorade. It was developed for the University of Florida in the United States. And what they did was they collected sweat from their athletes, analyzed it, and then created a salt solution to match what they were sweating out. The trouble is it tasted horrible. So they just added a whole bunch of sugar to it in order to get the athletes to consume the salt solutions. And that's how Gatorade became a product. So explaining the 4.5, explaining why would you administer the 0.45% saline in a 2-to-1 ratio? You don't have to administer it in a 2-to-1 ratio. But if you would take isotonic saline, the 0.9% saline, and want to change it into 0.45, you would then just dilute it in half. So it doesn't have to be administered as a 2-to-1 ratio, but if you would want to create it yourself from isotonic saline, you would just dilute it with sterile water to half of its strength, and then that would give you the 0.45% saline. Are there any factors that contribute to tonicity beside the concentration of the solutes? And the solutes that you're going to be most concerned about are the sodium and the chloride. The glucose you don't deal with as a tonic particle. The urea you don't deal with as a tonic particle. So it really is just the sodium and the chloride which is going to alter movement into and out of the cells. Question about if there's any difference in the fluid exchange mechanisms between absorbed through the GI tract and through IV access. The only difference is in speed. Once you absorb the stomach, you can absorb a small amount of fluid through the stomach, but the gastric endothelium is not terribly permeable to water. The duodenum is where most of the GI absorption occurs, but that's not going to happen until 20 minutes, 30 minutes after you've ingested a fluid. And if it's a fluid with any kind of salt in it, it may take even longer to empty out of the stomach. So that's why pure water will get absorbed more quickly because it gets into the duodenum more quickly. But other than speed, once it's absorbed through the GI tract, it gets dumped into the plasma. So it's just a different route for getting the electrolytes and the water into the plasma. Next question. When I wake up, I feel thirsty. What happens to the body when we sleep? Should I drink water before we sleep? Great question. So assuming you sleep for 8 hours, and when I sleep for 8 hours, I'm water deprived for all 8 hours. So unless I wake up in the middle of the night and ingest water, I've gone for 8 hours without any new water. Every time I exhale, I'm losing water in my breath. So you get progressively dehydrated as the night wears on. And if you would look at the urine production by the kidney, when you first go to sleep, the urine's putting out a mildly concentrated, the kidneys are putting out a mildly concentrated urine. By the time the morning comes around, ADH levels are increased and the kidneys are putting out a very concentrated urine. So your first morning urine is usually very concentrated. The loss of water through breathing, through sweating, through transpiration is also why when I want to feel better about myself and my diet, whether my diet's working or not, you always weigh yourself first thing in the morning because that water loss has contributed to a lower body weight when you wake up in the morning. Question outside the discussion, but how do you memorize the mechanisms that you've explained? Do you have a YouTube account for that explanation? And no, I do not. How do I say this kindly? I'm old. So I've not fully embraced the concept of YouTube as a mechanism for explaining things. There are, however, excellent examples of YouTube explanations, and I use a number of them in my class. I'm very willing to use resources that other people have created on YouTube, but I've never had any burning desire to try and create my own. So that's, old people don't like technology. I hate to perpetuate the stereotype, but I'm one of them. Okay. Are there any other questions?
Udah, fokus kamu silakan, Dek. Masih ada pertanyaan?
If not, I think we come to an end of the session, Dr. Diaz.
Okay, thank you very much, Prof, for your nice lecture. So there's no any more questions, students? Yeah. Okay, I think there's no any more question, Prof. Thank you very much, Prof, for your nice lecture. Of course, this lecture opened up our insight, especially regarding body weight. Thank you very much, Prof. We hope you can visit Indonesia again, dear student. Please unmute and say thank you to Prof.
Sure.
Thank you, Prof.
Thank you,
Prof.
Thank you, Prof.
Ya, Aziz.
Thank you,
Selamat pagi.
Thank you, Prof.
Prof, as Prof Irfan said before, we have manuscript. Dek, adik-adik boleh live, sudah boleh live, Dek.
Halo, Prof.
Hey, Dr. Ika, how you doing?
Yeah. I'm fine, Prof. We have revised our manuscript, Prof.
Okay, do we want to stop the recording and
Yeah, okay.
remove the students?
Recording dulu.
Okay. So, yes, what did you think of the